Hello, I'm Parul Tandon, a gastroenterology resident at the University of Toronto. I would like to welcome you to our inflammatory bowel disease educational video series sponsored by educational grants from the Canadian Association of Gastroenterology and AbbVie Canada. These videos were developed to target critical issues in IBD that are routinely encountered in inpatient and outpatient care. Recent published evidence suggests that Canadian gastroenterology trainees are not fully satisfied with the level of IBD exposure under the current training model, and several topics appear to be inadequately covered during training. As such, our aim is to provide a comprehensive update on core and complex inflammatory bowel disease topics to improve trainee knowledge and overall confidence levels. We plan to do this by interviewing Canadian inflammatory bowel disease experts in an engaging and interactive format. The target audience for this program includes gastroenterology trainees and early career physicians managing patients with inflammatory bowel disease. This program is an accredited self-assessment program under Section 3 as defined by the Maintenance of Certification Program of the Royal College of Physicians and Surgeons of Canada and approved by the Canadian Association of Gastroenterology. Each module is approved for 2 hours of Section 3 credits for a total of 6 credits for all trainee modules. Please remember, the accreditation expires March 15, 2022. The Mount Sinai Hospital and University of Toronto Division of Gastroenterology allow for the posting of the program for educational purposes only. The information, dialogue, and included slides are presented by faculty specifically selected and recognized as national experts in the field. The content of this program is to be used for educational purposes only, and the participants of each video assume no liability for the information herein. This is video 1 of the series. It will address the key principles in preventative care in inflammatory bowel disease. We will address specifically vaccination practices in IBD patients with a particular emphasis on the neurobiologic therapies, discuss bone protection and osteoporosis screening, cancer surveillance, and finally, we will touch upon mental health screening. Joining us is Dr. Zane Gallinger, an inflammatory bowel disease expert and gastroenterologist at Mount Sinai Hospital in Toronto, Ontario. Dr. Gallinger completed his gastroenterology training at the University of Toronto and then proceeded to complete an advanced IBD fellowship at the Mount Sinai Hospital in New York. He returned to Toronto and now is focused on medical education in gastroenterology and IBD. Thank you, Dr. Gallinger, for joining us today and educating our viewers on the important topic of preventive care in inflammatory bowel disease.
Thank you very much for inviting me today. I'm really looking forward to getting into this module so we can help our learners understand more about preventative care in inflammatory bowel disease.
So I think the topic of preventative care in inflammatory bowel disease is very important for our viewers to understand. As gastroenterologists, we are following these patients very closely, especially in the flare period. And these patients are often immunosuppressed. So let's talk a little bit about why this topic is so important for our viewers to understand.
That's a great question, Parul. Vaccination uptake is of the most importance in our IBD population. We know that from survey-based studies, gastroenterologists, particularly IBD specialists, routinely prescribe immunosuppressive agents, but over 40% are not sure which vaccines are indicated and contraindicated in IBD patients. Furthermore, other studies have shown that we have a major vaccination issue in IBD patients. 28% of patients reported regular flu shots, less than 10% received the pneumococcal vaccine, and less than 15% were vaccinated against hepatitis B. This is concerning as we know IBD itself can increase the risk of developing vaccine-preventable illnesses, a risk further exacerbated by use of immunosuppressive therapy. With the increased rates of MMR and influenza in the general population, it's of the utmost importance that we vaccinate our high-risk IBD population.
So those are very astonishing numbers. So what factors do you recommend that healthcare providers look at when recommending specific vaccines for these patients?
There are several factors to take into account when considering vaccination. First is the level of immunosuppression of your IBD patient. The CDC divides immunosuppression into low-level and high-level. Low-level immunosuppression includes daily doses of corticosteroids of less than 20 milligrams per day equivalent of prednisone for more than 14 days and within 3 months of discontinuation or receiving alternate day corticosteroids. Doses of methotrexate of less than 0.4 milligrams per kilogram per week and within 3 months of stopping. Azathioprine of less than 3 milligrams per kilogram per day or 6-MP of less than 1.5 milligrams per kilogram per day and within 3 months of stopping. You see that these are typical doses used in patients with IBD. High-level immunosuppression is doses beyond those of low-level immunosuppression. Furthermore, the IDSA states that patients on anti-TNF therapy have high level of immunosuppression. For vedolizumab, the package insert says that patients should receive non-live vaccines, and that live vaccines if benefits greater than risk. Patients on ustekinumab should not receive live vaccines, and immune responses with non-live vaccines can be safely administered, but immune responses may be insufficient. Second, one must take into account whether the vaccination is inactivated or a live vaccine. Inactivated vaccines are essentially denatured viral or bacterial proteins that produce weaker immune responses compared to live vaccines and require boosters in the future. These are safe in all patients and should not be withheld due to the level of immunosuppression. On the contrary, live vaccines are attenuated forms of infectious organisms, produce stronger immune responses, and are strongly contraindicated in those on immunosuppressive therapy.
So two factors, the degree of immunosuppression and the type of vaccine. That makes sense. So let's start with inactivated vaccines. What would you recommend in prescribing these vaccines in the immunosuppressed patient?
Since inactivated vaccinations are safe in all patients with IBD, regardless of therapy or level of immunosuppression, they should receive all these vaccinations as per the guidelines. The first important vaccine is the influenza vaccine. Patients with IBD are at an increased risk of developing influenza and increased risk of influenza-related complications, such as pneumonia and hospitalization. As such, all patients over 6 months of age should be vaccinated every year, and this holds true for patients with IBD. It is important to note that the intramuscular or intradermal inactivated influenza vaccine should be used and not the live intranasal vaccination in patients on immunosuppression. If possible, influenza vaccine should be administered prior to starting immunosuppressive therapy, but more and more studies have demonstrated that vaccination at time of infliximab infusion dose does not impact serologic response. Those on combination immunomodulators and biologic therapy may have a blunted immune response to influenza vaccine, potentially making them less effective. So, if at all possible, try to immunize prior to the start of combination therapy. Similarly, IBD patients are also at an increased risk for pneumonia compared to the general population, especially those on immunosuppressive and narcotic therapy. There are 2 vaccines for pneumonia healthcare providers should be aware of. The 23-valent pneumococcal polysaccharide vaccine contains 23 various serotypes, and the 13-valent pneumococcal conjugate vaccine contains the 13 most common and virulent strains. Both are recommended for those receiving immunosuppressive treatment. All IBD patients should be vaccinated once with the PCV13 followed by PPSV23. If previously vaccinated with PPSV23, then the PCV13 should be administered at least 1 year after the PPSV23 in all adults. For viral hepatitis, they should be vaccinated as per the ACIP guidelines. This means that at the first visit for the patient, if you're considering biologic therapy or immunosuppressive therapy, you need to check the HAV and HBV titers. If they're not immune to HAV, they should receive a vaccination at 0 months and then at 6 to 12 months later after the first dose. For HBV vaccination, they should receive a vaccination, if not immune, at 0 months, 1 month, and then 6 months after the first dose. For Tdap, they should receive a vaccination every 10 years or in the setting of exposure to wounds.
So that was a great summary on non-live vaccines and hopefully very informative for our viewers. Let's shift our focus on to live vaccines. What would you recommend in the immunosuppressed patient?
So we should not vaccinate patients with live vaccines who are immunosuppressed. And in fact, the IDSA guidelines suggest that you need to wait at least 4 weeks after receiving a live vaccination before starting immunosuppressive therapy. And if you've been exposed to immunosuppressive therapy, you should probably wait at least 3 months after before receiving your first live vaccine.
So that makes sense. Let's comment specifically on the herpes zoster vaccine and the varicella, the 2 most encountered vaccines in these patients.
So herpes zoster, as we know, is a painful dermatomal eruption that is a result of reactivation of the latent varicella virus. The herpes zoster vaccine, also known as Zostavax, is a live attenuated vaccine and is licensed for all adults aged greater than 60 years as a single-dose injection. What's important here is that as per the CDC guidelines, patients on a low-dose immunosuppression can safely receive the Zostavax vaccine. However, in those on high-dose immunosuppression, such as anti-TNF agents, Zostavax administration is currently contraindicated. It is important to remember Zostavax should be given to patients aged greater than 60 years if it can be administered greater than 4 weeks before beginning highly immunosuppressive therapy. as you know, varicella is highly contagious, spread by direct contact with vesicles, and occurs at higher rates in the IBD population. The varicella vaccine is a live attenuated vaccine, and as per the ACIP guideline, children without prior chickenpox should receive 2 doses of the varicella vaccine at 12 to 15 months of age and at 4 to 6 years of age. People 13 years of age and older who have never had chickenpox or received chickenpox vaccine should get 2 doses at least 28 days apart. Again, the varicella vaccine is safe in those on low-dose immunosuppression, though its administration in anti-TNF exposed patients remains controversial. Prior to administering the varicella vaccine, it is recommended immunity is checked and vaccination only be provided if non-immune status is confirmed.
So with respect to the zoster vaccine, as you know, the tofacitinib was approved in Canada in October of 2018. Can you comment specifically on the zoster vaccine in patients receiving tofacitinib for their inflammatory bowel disease?
It's a very good question and a very relevant question because we're going to be seeing increased uptake in the use of oral JAK2 inhibitors, and therefore it's going to be very important for us to know why we need to vaccinate these patients with the zoster vaccine. Tofacitinib has been associated with increased herpes zoster risk for all indications, either approved or under investigation, and this risk appears to be dose-dependent. We know from the landmark Octave trials, the rate of shingles were seen in 1.5% of the tofacitinib 5 mg POBID group, 5.1% in the 10 mg POBID group, and only 0.5% in the placebo group. Recently, a non-live vaccine, Shingrix, was approved in the US and Canada with a sustained efficacy against herpes zosters of greater than 90%. While limited data exists, expert opinion has suggested that Shingrix can be safely administered in ulcerative colitis patients starting tofacitinib for the prevention of shingles. As per CDC, 2 doses, separated by 2 to 6 months for adults over the age of 50 is recommended. It remains unclear whether the Shingrix vaccine is indicated in patients who received the varicella vaccine and have subsequently not acquired natural immunity.
Let's move on to vedolizumab. We're seeing and using vedolizumab a lot more in our inflammatory bowel disease patients. Could you specifically comment on vaccinations in these particular patients?
Yes, absolutely. This is a question that comes up all the time. As you know, vedolizumab is an anti-integrin that targets white blood cells trafficking into the gut. As per the product monograph, you should consider giving all vaccinations as per guidelines prior to starting therapy. Besides oral live vaccinations, all vaccinations can be provided to the patient if the benefit outweighs the risk.
So with respect to live vaccines, is it safe to vaccinate family members of patients with inflammatory bowel disease?
That's a great question that I receive from both patients and family members all the time. Based on best available evidence and IDSA guidelines, family members, if immunocompetent, can receive live vaccinations. This includes rotavirus, MMR, varicella vaccination.
Let's shift gears to travel vaccinations. As you know, a lot of our IBD patients are young and travel for leisure or work purposes. Could you comment on specifically vaccinations for travel purposes and when patients endorse travel plans?
I have this conversation with my patients all the time, and a lot of them are scared to travel because of the medications they take and their IBD symptoms, and they really shouldn't be. And that's why it's really important to have a thorough conversation on this topic. First and foremost, if they're worried about traveling to a specific area, they should consult with an expert in travel medicine. In fact, the ACG guidelines recommend that all IBD patients be evaluated at a traveler's clinic at least 3 months before their departure so that necessary vaccinations be administered. Perhaps the most important live vaccine to be aware of is the yellow fever vaccine. The yellow fever virus is transmitted through the bite of an infected mosquito and is found in South America and Africa. The yellow fever virus is a live attenuated vaccine and there is no inactivated form. Those on immunosuppressive therapy really have 2 options. Either they be advised to forego travels to endemic areas because of the high risk if therapy cannot be stopped, or they should withhold their immunosuppressive therapy for at least 3 months prior to vaccination if possible.
So that was an excellent summary on the overall topic of vaccination in IBD patients. Let's shift gear to bone protection. Is it important to consider, and how should we incorporate it into our daily practice?
It's a very good question because it's an area that's often overlooked. As you know, chronic inflammatory conditions are associated with accelerated bone remodeling and destruction, and therefore, patients who have inflammatory conditions are at increased risk for associated fractures. In fact, in the IBD population, Rates of osteopenia have been shown to be as high as 77% and osteoporosis as high as 41%, and this correlates with significant increased risk for fractures. Factors that may accelerate or contribute to bone loss in IBD are corticosteroid therapy, with at least twice as high risk of osteoporosis in those who use corticosteroids compared to those who have not. Furthermore, at least 17% of patients on steroids will develop fractures within the first year of steroid use, and this risk is increased in those greater than the age of 65, those with low calcium intakes, and the female gender. Concurrent smoking is a very strong risk factor for bone loss, and this occurs in a dose-dependent effect. The mechanism by which this occurs includes alteration of vitamin D metabolism, reduction in gastrointestinal calcium absorption, and alteration in estrogen production and metabolism. Furthermore, active smoking is associated with relapses in IBD, resulting in increased steroid use. Finally, low BMI is a well-documented risk factor for lower bone mineral density and increased risk of fractures, and this also holds true for the IBD population.
Okay, so then what should we be recommending in terms of bone mass screening in the IBD patient?
The gold standard test for all patients, including patients with IBD, remains the DEXA scan. Measurements are obtained from the femoral neck and lumbar spine and displayed as both Z-scores and T-scores. Osteoporosis is defined as a T-score below -2.5, whereas a score between -1 and -2.5 is osteopenia. As per the ACG guidelines, patients with conventional risk factors for abnormal bone mineral density with ulcerative colitis and Crohn's disease should undergo screening for osteoporosis with bone mineral density testing at the time of diagnosis and periodically after diagnosis. Low threshold should be maintained for screening individuals who have used corticosteroid therapies at any time. Bone mineral density measurement with a DEXA scan is recommended in all patients starting oral corticosteroid therapy, specifically in those who have used oral corticosteroid therapy for longer than 3 consecutive months in a dose greater than or equal to 7.5 milligrams per day of prednisone equivalent in the absence of baseline bone mineral density measurement.
So that was an excellent summary on osteoporosis and inflammatory bowel disease. Let's shift gears once again and let's talk about cancer screening in these particular patients. Any pearls you want to pass on to our viewers?
I think it's very important that we work very closely with primary care providers to provide age-appropriate cancer surveillance in patients with IBD. The first area I wanted to discuss was cervical cancer. As we are all aware, cervical cancer is caused by the human papillomavirus. Patients with IBD are at a higher risk of developing cervical cancer, especially if on chronic immunosuppression. As per the CDC, the HPV vaccine is recommended for young women through age 26 and young men through age 21, with 3 doses at 0 months, 2 months, and 6 months. However, it is still strongly recommended by both the CDC and the American College of Obstetricians and Gynecologists that women who have a history of chronic immunosuppression be screened annually with pap smears. When discussing IBD and its therapies, we need to touch upon melanoma and non-melanoma skin cancers, especially with the widespread use of anti-TNF therapy and immunosuppression, including the thiopurines. In fact, IBD itself is associated with an approximately 37% increased risk of melanoma compared to the general population, but this does not hold true for non-melanoma skin cancer. What appears to increase the risk of squamous cell cancers and basal cell cancers in patients with IBD is the use of thiopurines in particular. For melanoma, the use of anti-TNF for 1 year confers almost a 2-fold increase in developing melanoma, but no large prospective studies have validated these initial observations. Because of these concerns, patients who have ulcerative colitis and Crohn's disease should be screened for melanoma independent of the use of biologic therapy, and for those on immunosuppressive therapies, they should be screened for non-melanoma skin cancer, particularly if they are over the age of 50.
Let's talk about colorectal cancer screening. Who should receive screening for colorectal cancer and how often?
So as you know, patients with ulcerative colitis and Crohn's colitis are at increased risk of colorectal cancer compared to the general population, and it is these patients that we should be focusing on in order to detect dysplasia in its early stages. As per the ASGE, AGA, and ECHO guidelines, the first screening colonoscopy should be offered 8 years after a Crohn's colitis or ulcerative colitis diagnosis, but those diagnosed with primary sclerosing cholangitis should get a colonoscopy soon after diagnosis and annually thereafter. This includes all patients diagnosed with ulcerative colitis regardless of extent, patients with Crohn's disease, which affects at least 1/3 of the colon, or complex perianal disease, patients with IBD-U. It should also be mentioned that those with first-degree relatives who have been diagnosed with colorectal cancer at an age less than 50 should be offered their first colonoscopy 10 years before the age of the diagnosis of their family member, or 8 years after the diagnosis of inflammatory bowel disease, whichever occurs earlier. It should be noted two things. First is that the interval at which you receive these colonoscopies varies depending on the guideline. The second point to mention is that with the advent of chromoendoscopy and improvement in endoscopic techniques, it is likely that these guidelines will continue to adapt over the next few years. I would like to make two other points. The first is that the interval at which these colonoscopies should be provided changed depending on the guideline, so I'd recommend you refer to the guidelines when making these important decisions. The second point I want to make is, with the advent of chromoendoscopy and improvement in endoscopic techniques, it is likely that these guidelines are going to change over the next few years.
Let's finally talk about mental health awareness, such an important topic, especially in patients with chronic inflammatory diseases. Could you provide some words of wisdom?
Absolutely, and a day doesn't go by where we don't see a patient with a mental health issue in our IBD clinics, and I think it's really, really important that we focus on this a bit more. And this requires a long conversation, so I'll really try and briefly touch upon it, but it's incredibly under-recognized and under-treated in our IBD population. Recent studies show that up to 20% of IBD patients have been formally diagnosed with anxiety, and up to 22% of patients have been formally diagnosed with depression. Furthermore, researchers have determined that those with depression at baseline, according to the PHQ score, had significantly higher risk of severe disease, higher risk of relapse, were more likely to receive new biologic and steroids, more likely to be hospitalized, and more likely to undergo surgery compared to those without depression. It is critical to assess for depression accurately to identify those patients at risk of worsening mental health concerns. The recently released ACG guidelines for preventative health in patients with IBD do recommend screening for anxiety and depression in patients with IBD. They don't explicitly say how to do this, but we do know that simply asking about anxiety and depression is likely not enough. Some scales, such as the PHQ-9, can be used for screening for depression.
Well, Dr. Gallinger, well said. And thank you for joining us today for educating our viewers on an important topic, preventative care in inflammatory bowel disease.
It was really a pleasure to be here today, and I hope that some of the topics we discussed will help other gastroenterologists treat and improve the lives of those with IBD.